We'll move on to the next speaker, who is Professor Andrew Kneebone. He's a senior staff specialist in radiation oncology at the Royal North Shore and Gosford Hospitals in Sydney, Australia, as well as Genesis Cancer Care. He's got more than 30 years of experience in leading GU and gastrointestinal cancers, including being active in the AGITG trials group since 2006. He's going to talk to us about the evolving role of radiation for rectal cancer. Thanks, Andrew.
Thank you, Meredith, and thank you very much for the invitation to speak. It's very flattering for an old fart like myself. And conflicts of interest, I've got no conflicts of interest to declare, though I am a middle child, and my mum says I'm very needy, want to be loved, so it's shaped my personality. And obviously a lot of the theme for this meeting is ethnicity and diversity, and I want to give hats off to the Kiwis because I think they truly recognise and respect their Indigenous population, and it really saddens me that the same is not this in Australia and as seen in our referendum. So I really think you've done so much better than we have in Australia. And the other thing that's really hit me that, I don't know if for those who don't know, I'm from North Shore, which is a very affluent part of Sydney and about 80% privately insured, and we've got full access to everything, and I'm making recommendations in that sort of work environment. So just recognise that, and you guys can sort of shout me down with my recommendations about the role of radiotherapy. And, you know, when you recognise radiation on-course chemo-RT, it's, 6 weeks of treatment often. You recommend watchful waiting and MRIs, which aren't reimbursed, the timely scopes, radiologists with actual experience reporting the MRIs post-treatment. So there's a lot of things that I have full access to that others don't. And I think there is flexibility in rectal cancer management that you can adjust management and still give good quality care without sort of being so rigid in the ways that you have to do things. The Rapido and the Pro-D trials came out about 2-3 years ago, and they both showed a 7% improvement in disease-free survival with TNT. And so we now need to consider this for locally advanced rectal cancer. But then it's suddenly got much more complex. What is the optimal sequencing of chemo and chemo-RT? Is there a role for short-course radiotherapy? And then there's come the role of watchful waiting and how best to do it. And then the Prospect trial came out just very recently, and the role of induction chemo and dropping radiation altogether. And so there's a wide variety of practice across the country. This case has vexed me throughout my career, and it's not meant to be a tricky case. It's a 63-year-old with a mid-rectal cancer, say 7 centimetres from the anal verge. It's restorable with appropriate surgery. And I don't think there's standard approach, and I might even just so I know where everyone's at, who would just recommend for this case? You can see on the MRI there's some nodes that they think are involved, there's maybe some extramural venous invasion, but it's well clear of the mesorectal fascia. Just so I get a sort of vibe where we're at and where I need to pitch. Hands up, just who would recommend upfront surgery? Just go straight to an operation, cut it out? No one's doing that. Who would recommend chemo-RT and then resection? So small numbers. Who'd recommend TNT? Let's start hitting it. And then who'd recommend neoadjuvant chemo like Prospect? Okay, so my recommendation at the end is going to be different to the majority of people. So we'll see if I'm going to influence anything from the audience. So, why am I dragging up this old study? So this was the Dutch TME study of short-course radiotherapy prior to TME. It was a big impact at the time because for the first time we had a trial with good quality surgery. Overall survival was the same, but what a lot of people haven't sort of analysed in this paper is the subgroup analysis of which patients really truly benefited from short-course radiotherapy. So overall radiotherapy halved the risk of local recurrence from 11.4 to 5.8. You can see that in the APR group that short course didn't have much of a benefit, so 14 down to 9.3. And when the APR group where the margin was positive, short course did very poorly and had 20% local recurrence. The group that it really did most benefit from was short course was actually in the mid-rectal cancers from the 5 to 10 centimetre mark, and also did have the degree of benefit for node-positive patients. keep that sort of figures in your mind. And then what this has probably haunted us for 23 years is the complications reported with the short course radiotherapy, and the rates of fecal incontinence 62 versus 38% with short course radiotherapy, and this has given radiotherapy a bad name, and you've got to remember that the radiotherapy in this study was given using coloured pencils on a big China graph on an X-ray. But radoncs now, with this information, have said, look, we've embraced modern techniques, and we've also embraced not irradiating the anal canal unless you really need to. So I think, quoting these, from 30 years ago, the toxicity, you've got to be a bit careful. And then came in 2004, so almost 20 years ago, the SAUDA German trial of pre-op versus post-op, and basically, it's made us not want to give post-op whatsoever, much higher rates of toxicity and long-term toxic side effects, and it's set the benchmark of local recurrence rates of around 6% with preoperative chemo-RT. And then we agonised over, do you give short course, which was much more convenient, versus long course? And TROG, to their credit, did the short course versus chemo-RT, and it's fascinating how this study can be taken both ways. There's no statistical difference, so you can say they're the same, but I think many of us felt that there was an improvement in local control from 7.5 to 4.4 with long course chemo-RT, and really we got very nervous about the 12.5% local failure rate in those distal third, the majority of those recurring, and APR. And so that's become very much dogma that we don't like short course for the distal third of the rectum. And it's also interesting, very few studies, even the modern studies, don't report late toxicity of radiotherapy. And when you have a radiation design trial, it was 7% at 3 years was late toxicity with both radiation arms, so much lower than reported in the previous Dutch study. And so this, for about 15 years, they used to dust me off and go to the Colorectal Surgical Society meetings, and this was the protocol that we used to table at the meeting. And this has been, for 15 years, what we've managed our rectal patients. So we divide the rectal patients into less than 5 centimetres, 5 to 10, and more than 10 centimetres. And we don't like the distal third, and so once you have full thickness, T2, any T3, no positive distal third, we've recommended long course chemo-RT, and then 6 weeks later resection. And then the mid-rectal cancer, if the mesorectal fascia is threatened, we feel that chemo-RT was standard, and then it was really dealer's choice for the T3 or no positive, whether you give short course or chemo-RT. And for the 10 centimetres and above, you really needed a mesorectal fascia that was compromised before you'd recommend chemo-RT. So that was our standard approach, and there's been a lot of soul searching recently about how this approach has changed. And sometimes, as a humble radiation oncologist, I felt, browbeaten by the surgeons, but my good quality surgery, you don't need radiotherapy. I did an editorial, is radiotherapy the work of the devil? And wow, did I get some feedback on that sort of editorial, so I've learnt my lesson. But that's sometimes the way that you feel. And then when you start, then the reason why surgical practice has started to change is more and more data coming through, like this meta-analysis of 41,000 patients, and said, radiotherapy only impacts on local recurrence and not impacts on disease-free survival, metastasis-free survival, or overall survival. The Mercury study has been quite an influential study in our community, and where the POMs used MRI staging with high quality centralised review, and really they started saying that the local recurrence is really good. You can see the red curve is with the local recurrence with the 1 millimetre margin on the MRI scan, and that's when you have the tumour within 1 millimetre, then you're starting to get 20-25% local recurrences. But if you've got less than that, greater margin than 1 millimetre, then your local recurrence rates really starts plummeting down. And the Germans have shown very similar things. They started using MRI, and they said, look, they'll call a high risk if it's T4, if the tumour's within 1 millimetre of the mesorectal fascia, or if it was a T3 in a lower third. And they gave them chemo-RT and then resection, and then they had a local recurrence of 2.7%, and then all the others, they went straight to surgery. And so with that case that I was talking to you beforehand, I was giving agonised. First I gave short course, and then I gave chemo-RT, and then suddenly with the German and the Mercury people, I was starting to say, look, you go straight to surgery. So my management has changed over the period of 10 years. And then just to make life really difficult, then came the watch and wait data coming through, and so this was 2017, series of about 850 patients, watch and wait, and you see that in the watch and wait group, they said there's a 30% rate of recurrence if patients are observed after a complete clinical response, but it didn't seem to majorly affect overall survival. And well, I think that's divided and when you do straw polls about whether you adopt watch and wait, we're really divided in our oncology community, and it'll be good to really get the feeling there's no randomised trials showing that watch and wait is as safe or as effective as proceeding straight to surgery. And often I was agonising whether you offer it to patients, and in many ways you keep a bit quiet, but if the patient says, I refuse a stoma, then you say, well, there is this concept of watch and wait. And so it's actually patient-driven asking about this sort of approach. And so it's only 2-3 years ago that the Rapido and the Prodige trials became published. So we have known about them for a while. So these are the two trials of TNT, which has become the vogue. The standard arm, the control arm for both trials was identical. It was long course chemo-RT, TME resection, and then adjuvant chemotherapy afterwards. And then the investigational arms, so when you say TNT, it's not the same. So the Rapido had short course radiotherapy, then chemotherapy, and then the surgery. And when the Prodige trial had induction chemotherapy, and then chemo-RT, and then surgery. So different TNTs. And in many ways remarkably similar when you look at their results. So both showed a 7% improvement in disease-free survival at 3 years, and that I think many of us in the oncology community accept that as a valid and clinically meaningful endpoint. And that 7% improvement in DFS was largely driven by a reduction in distant metastases. And so you're starting to feel guilty for all the patients that I've treated, that you give them 2 weeks to organise radiation, 5 weeks of treatment, 6-week delay, then a month after the operation. You're delaying good systemic therapy for 4 or 5 months when you give chemo-RT and then wait for the chemo to be given after the surgery. So you're going, wow, have I started recommending holding off chemo for 5 months? Have I done the wrong thing? And so there does beg the question, which we'll address later, do you need the radiotherapy? Now, the local relapse in the short course and the Rapido was 8.3%. And I know we're not allowed cross-trial comparisons, but when you compare it with Prodige, 4.8? My eyesight's going. And that 8.3%, I think, is starting to get too high, and makes me sort of apprehensive about sort of adopting the Rapido. So you've got to be selective where you give the short course, I think. So just when I was starting to avoid radiotherapy for my mid-rectal lady and said, go to surgery, then I'm suddenly starting to think, oh shit, should I be giving TNT for this lady with a 7% survival benefit? And then we've had a flurry of interesting trials, and I've actually found it fascinating working through them. Then last year, the Oprah trial was published, and so this explored TNT, and then basically they looked at the sequencing of the chemotherapy and the chemoradiation. So one had chemo first, and then the chemo-RT, and then the other approach was chemo-RT first, and then the chemotherapy. And then what's, in a well-conducted trial, then they said if you had a complete clinical and radiologic response, then we'll watch and wait you. And so gave fascinating data. First thing that knocked my socks off was actually 72 to 76% of men in this study had they labelled a complete clinical response, which was really much higher than what I was expecting. It wasn't too much difference between the two arms, it was 72 versus 76%. And then they give you good data about what is the success of watch and wait. So 27% regrowth in the consolidation chemotherapy arm. And then you've got to be mindful that 24%, if it comes back, 24% were not successfully salvaged with the subsequent surgery. And overall, there was a 6% local recurrence rate at 3 years. But you can see that if you're trying to say, okay, if I'm giving TNT, if you're gunning for, organ preservation, keeping the anus and the rectum, the best approach was the chemo-RT first and then the chemotherapy. But there's a cost for that, and a huge cost is that you're delaying surgery, and there's a long time, can be months or even years before you give the surgery. And then I'm going to try to tie everything together, I promise. And then comes the Prospect trial, pretty impressive US study of 1,200 patients. Standard control arm again was chemo-RT and then the surgery, and then adjuvant chemo. And the investigational arm was to give induction chemotherapy. If he didn't, it's hard to understand how they assessed this 20% response, but if he didn't respond well, then they recommended jumping ahead to chemo-RT. So about 10% of patients received chemo-RT on the induction chemo, and then resect, and then they could have some further chemotherapy afterwards. And you've just got to remember, in the Prospect trial, they were more favourable patients. So they didn't include those who needed APR, so you had to have the sphincter preserving surgery. And anyone on the mesorectal fascia said, no, we're nervous about chemotherapy. So they're a bit like the patients in my vexing case. And wow, radiation oncology needs a better marketing manager. The Telegraph said, thousands of bowel cancer patients spared brutal radiotherapy study finds. And it was even on the ASCO website. It was removed later on, but that was the thrust of discussions. And when you read the paper, I would actually argue that the chemo-RT arm is the winner. When you look at numerically 5-year survival, 90.2 versus 89.8. So I know that, and the lower local recurrence 1.6 versus 1.8. So numerically, you can't argue that chemo is better. And then if you say brutal side effects, I would say grade 4 is life-threatening. There's actually triple the death rate with the chemo over the chemo-RT. So radiotherapy arm had half the rate of severe life-threatening toxicity. There's no documented late toxicity in the paper at all to say it was brutal. And chemoradiotherapy is over in half the time of chemotherapy. So it's just amazing how instantly they said the chemo arm, the induction chemotherapy, was the better approach. And then comes, so that the conclusion, the way most people take it, the two approaches were identical in oncologic outcomes. And then you've got to say, well, we know TNT is better than chemo-RT. Are we happy giving induction chemotherapy? And when I've agonised over this sort of study, these patients are going to get chemo anyway, aren't they? The T3 node positive, they're going to get chemotherapy. A local recurrence rate of 1.8% is some of the best local recurrence rates I've seen in any clinical trial of rectal cancer. So for the selected patients in the PROSPECT trial, despite all my misgivings about the labelling of radiation treatment, you can make a strong argument for recommending induction chemotherapy for these patients. So tying it all together, and I'll give you my recommended protocol, which people can sort of criticise heavily. So I think TNT should be the standard of care for low rectal cancer to try to prevent APR. And any other rectal cancer where the mesorectal fascia is compromised, and I haven't talked much about if you've got pelvic sidewall nodes involved, but the surgeons aren't going to dissect. I think you need those nodes sterilised, and you need long-course chemo-RT to sterilise the pelvic nodes. And if you're gunning for organ preservation, then recommend induction chemo-RT, then you have the consolidation chemo based on OPERA, and then you quote a patient a 50-50 chance of obtaining organ preservation. But patients have to be aware there's a 30% recurrence on watch and wait. If you get a complete response, it is intensive, it's costly, MRIs are not reimbursed, so it's a real cow, and a quarter are not salvaged. And what is also you've got to be really aware of, that surgery can be much more challenging if you're operating 4, 5, 6 months if you don't respond, or alternatively years down the track if you have a late recurrence. And so many cases the surgery, what was once maybe a sphincter preserving, has to become an APR. So back to my original case, so the 63-year-old lady, if I gave her TNT now, which was probably the most common response, she's got a 50% chance of requiring salvage surgery. And the surgery is going to be more challenging, and I would argue, highly likely to require an APR. And also, if she has late surgery, a coloanal anastomosis in a radiated rectum, her anal function is going to be very poor. So in her particular case, I think you can make a strong recommendation for neoadjuvant chemotherapy. But then again, I've changed my mind how I'd managed this case about 6 different change of minds over the last 15 years. But at the moment, that's where I would be voting, if I was discussing a case at our MDT. And so this is my current approach and protocol that we have. So for the less than 5 centimetres, if it's once you start, getting decent size, early T3, no positivity, then I'm a believer in TNT. I don't think you've got much to lose because you're going to need an APR anyway. So I'd be going chemo-RT first and then consolidation chemo. And I am comfortable with a watch and wait, but patients really have to be counselled what's involved. For the mid-rectal cancers and the upper cancers, then I only give radiation treatment now if the mesorectal fascia is compromised. For that, always the mid-rectal and the T3 mesorectal fascia nodes involved, I am happy with chemo than surgery. So that's the evolving recommendations from Dodgy Dr. Kneebone. Okay, I think that's it. Thank you very much.
Thank you so much. Oh, sorry. Thank you so much, Andrew, for that really fascinating overview, just highlighting a lot of the complexities, and I think everyone would agree, how many sort of still unanswered questions and conundrums we face in our MDTs with management of rectal cancer and, with all this new evolving evidence over the past couple of years particularly. I think we've got time for some questions. Yeah.
So we can probably go for a couple of questions. One for Jason. I will combine 2 questions, Jason. So how can primary and community care services be integrated into delivery of cancer care to reduce the inequality? And then second part is like how close we can move the chemotherapy to improve the equity.
How can we move the chemotherapy?
Yes, how closer we can move
Yes.
to the home, like.
Thankfully, the answer is kind of both the same to both questions. So it's we have an amazing organisation which may not be around very long called Te Aka Whai Ora, which is the Māori Health Authority, and they were brought in by the previous government. And one of their key tasks was to try and figure out how to make care work better for Māori. And one of the most important messages that came through when you go out and talk to Māori is we want to be served by Māori, so we want to have people we recognise delivering care, and we want it closer to home. We don't want to have to travel. So I think the answer to those questions is improving our workforce and also changing who gets to play, who gets to be in the workforce. Aunties out in the community know where everyone is, they know how to get to everyone, they know where certain people are going to be at certain times of the day to get them into the care that they need, including primary care. And also reorienting our services so that instead of being focused on what works for the clinician, it's what works for the patient themselves. And these are universal things. This isn't just something that would work for Māori, this is something that would work for everyone. And so it's with sadness that Te Aka Whai Ora may not be in existence for very long, because these are exactly the kinds of questions that we need to tackle. And so I would love to see those questions tackled in other ways, however we need to do it, because it's one of the big problems is trying to get care into a shape that makes it more palatable, acceptable for Māori to access as well.
Thank you. Maybe just one question to Andrew. Is there a space to adopt a risk stratification approach for adjuvant post-chemo RT and surgery based on PCR and ctDNA?
Yeah, and this leads on to the question, where is our research and where should we be heading for rectal cancer? And we've got to much better predict the 50% who are going to be organ preserved down the track. And, I love Steve Ackland's study of 5,000 patients getting some blood and plasma right at the very beginning and saying we've got to have better predictors of those who are long-term disease-free with chemo and chemo-RT and those that need surgery. And then we've got to do the whole follow-up protocol, the ATITG protocol. Yeah, wow, it's intensive. And hard to follow. So we've got a lot of room to manoeuvre and absolutely, getting the bloods, circulating DNA, tumour cells, any ways we can try to predict early assessment of response to predict those people that are the good players. That's what we need.
Thank you. Thanks.